physician in the middle of the night came to my room. He said, "Are you aware of how sick you are?" And I said, "Yes."
They call it a lot of different things. Death with dignity, doctor-assisted death, medical aid in dying.
He was very politely asking me if I wanted to die, and he would have made it happen.
This is an issue that's about making the medical professional more comfortable with killing people.
There's no killing going on. It's a request of a patient to take his or her life by their own doctor.
Well, it's a murder on request. It's a suicide with help.
She said, "I want the pills. Give me the pills."
It's the ultimate help.
The ultimate help.
Yeah.
Some doctors have had enough.
Instead of addressing his depression, she gave him the means to kill himself.
My job as a doctor is to alleviate their suffering. It's not to be a vending machine when they make a good, rational argument that they'd be better off dead.
But this is very different from a suicide in terms of this is a rational act by a person who's dying to control the timing and manner of their death.
But the laws keep expanding.
Will this also apply to patients with psychiatric disorders? Will this also apply to patients with Alzheimer's disease? Will this apply to babies? Will this apply to children?
I've traveled across oceans and continents to see if this debate is really about compassion.
A family who's looking at a frail elderly person and saying, you know, why don't you just do assisted suicide? Save us all the time.
Does that happen?
Yes, it happens.
Is it really about freedom?
I said, "It's my mom. Don't take her away."
About dignity?
They just killed my mother.
My name is Kevin Dunn. I worked in media most of my life. It was my father who got me hooked. He worked in television back in the early days. A few years ago, Dad was diagnosed with colon cancer. The treatments were almost as bad as the disease. Dad's worries about his illness and concern about becoming a burden made me wonder. Now that assisted dying laws are legal in this country, what are they really saying to people with a terminal illness? And now that doctors have the legal right to end the life of a patient, what is this saying to the House of Medicine? And how do these laws affect society over time? It's impossible to miss the news reports about patients asking for help and dying. They're heartbreaking stories. But is there a side to this issue we haven't heard yet? Where does it end? And have we gone too far? My 50,000-kilometer journey begins in the remote village of St. Anthony on the island of Newfoundland to meet Sheila Lewis and her daughter Candace.
Hi there, how are you? Oh wow, those are beautiful.
Candace was born with cerebral palsy and spina bifida. Sheila says she took Candace to the hospital last year to save her life. The doctors pretty much told her to abandon hope, but Sheila wasn't about to abandon her daughter.
If I had to go ahead and do what the doctors wanted me to do, I wouldn't have had her.
And what was that?
Well, they wanted me to do assisted death on her. She got sick here at home. We got the ambulance. When we got her to the hospital, she was having seizures. They had to give her medication, take her heart rate down. Her heart rate was very high, 170. This doctor that was seeing her first, and he came in and he told me that her kidney wasn't in the right spot. He told me the lower parts of her lungs had collapsed, so they admitted her. And the next day, when he came in, he talked to her, and then he took me out in the hallway, and he just stood me up against the wall, and he told me about assisted suicide. Death was legal in Canada, and I said, well, he asked, did I know? And I said, no. And then he said, he was all for it. And I said, well, that was your choice. And I told him I wasn't interested in anything to do with assisted death. And he told me, he said, I was being selfish. So I more or less walked away from her. She heard everything. And
This is your story. Yeah. You said a couple of things on the news story. I remember they said, did you want to die? And what did you say?
I don't.
You don't. And yet they were talking to you about dying.
Yeah.
Do you think that's good thing for a doctor or bad?
Bad.
Yeah. Why?
I don't know. I don't want to.
like not once did she ever say to them, I want to end my life. Not once. And this doctor that came in and next day after he told me about the assisted death and stuck his face down in hers and said, do you know how sick you are? And I'm just like, and when I got his eyes contact, I went my eyes like that to get out in the hallway, and I told him, I said, don't you ever pull something like that again. They had us told me that she was dying. I believed them. They were the doctors, and she was so sick, so. But I told her if she wanted to go, it was good. She could go. But she didn't, oh, honey. But she didn't want me to be alone. Don't cry. It's all done now. It's over.
Yeah.
We just don't want it to happen to anybody else, hey?
No.
Don't want another family to go through this.
In the first years after Canada passed its medical aid in dying law, nearly 2,000 people chose to have their life ended by a doctor. Candace and Sheila's story made me wonder how those choices are really being made. The way society looks at death is changing. One might argue that we have become so desensitized by the culture that even human life and death have become matters of personal choice. As of 2018, lawmakers in 5 countries and 6 U.S. jurisdictions have legalized doctor-assisted death. Proponents argue that people should have the right to choose the way they die. Critics say that choice is an illusion and a recipe for elder abuse and coercion when people are at their most vulnerable. It's under debate in almost every country in the world, and the United States is at a tipping point. So, what lessons can be learned from countries who have already passed assisted dying laws? So we're here in Amsterdam, in the beautiful Netherlands. Some people call it the most liberalized country in the world. The only thing more famous than this country's windmills are its progressive attitudes towards sex, relaxed rules for marijuana use, and laws that allow for euthanasia under certain criteria. Criteria that one Dutch journalist says just keep expanding.
Boundaries of euthanasia in the Netherlands seem to be blurred, and the situation seems to be shifting. And that's worrying.
Gerbert van Lonen says he's neutral on the issue of euthanasia, but he's concerned about where the law is heading.
We are discussing, just to mention a couple of issues, euthanasia for children, euthanasia for patients with an advanced stage of Alzheimer's disease, physician-assisted for psychiatric patients, assisted for people who are not ill but who are wary of life, who have the feeling that their lives are completed.
Who's telling the other side of the story?
I'm afraid no one.
Robert Schurig is a family physician. When we interviewed him, he was serving as CEO for the NVVE, or the Voluntary End of Life Society, whose website asks, do you have a death wish?
What you have to understand that in the Netherlands, we're very liberal, and we think it's your life, you have to decide upon your own life. 200 years ago, you wouldn't have needed the discussion about euthanasia because everybody would have died already.
It's true, people died earlier centuries ago, but euthanasia isn't a new idea. The original Hippocratic Oath, written more than 2,000 years ago, specifically forbids doctors from administering poison even when asked to do so. And in the Netherlands, they've been talking about euthanasia for nearly 50 years.
We had one member of High Court who said, well, whenever someone reaches a certain age, they should have a last will pill available to take their own life.
In 1991, Dr. Boudewijn Chabot made history by giving a lethal dose of medicine to a patient who wasn't suffering any terminal medical condition.
Many know you as the pioneer, if you will, of euthanasia here in the Netherlands. Does that title strike you strange?
I've got used to that, and in fact, in 1991, this was an exceptional thing to do, as there was no law in sight.
And what was the verdict in the end?
Guilty without punishment, which is very special for your country, I guess, because if you're guilty, you should be punished.
So the law was clearly being broken, but public sentiment was clearly shifting.
Have you had people come to ask you for euthanasia?
Yes.
Have you performed euthanasia?
Yes.
Robert Jonquier admits that the reason people are choosing to die is changing.
When we started in the Netherlands, our law, our euthanasia practice and our law, 85 to 90% of the cases were terminal physical situations. We have developed the last 15 years a situation where it became more and more clear that it was not about termination of terminal illness, but it was termination of suffering, and you can suffer of many things. You can also suffer from psychiatric situations, from existential situations, from dementia or whatever. I mean,
but doesn't that scare you? Doesn't it like to me it scares me. It scares me to think that it's going to keep on moving and moving and moving.
I don't believe it. I mean, that's the big difference and the big discussions we have around the world. I mean, the slippery slope argument. Once you start legalizing the situation, the option to euthanize a patient when he asks in a terminal situation, next you will see that doctors will go around killing patients when they have dementia.
Does that happen?
I don't think it is the simple way I describe it. That's not what's happening.
My mom, if she had been left in hospital without me visiting her and fighting for her, she wouldn't be here.
When somebody wanted to give up on you, you didn't give up.
My mom is 94 years old. She had a slip and a fall, and she was taken into hospital. And the only thing that appeared wrong with her was that she had an infection. The discussion at the time was, well, yeah, you know, we have a lot of things we have to do, and we don't know if it's worth it. They stopped to feed her, and they stopped administering water. And to me, it was looking like they were stopping and not looking and not going further to find out what is wrong with her. And unfortunately, my mom at that moment said, I don't want to live anymore. I cannot eat, I don't get water, I have pain, you're a moving mirror, I cannot live like this anymore. The nurse took this through to the doctor as a request for end of life. And there was a meeting with my mom to which I was not invited. And my mom told me that they had discussed end of life.
And they said that only 48 hours and no euthanasia.
So what about a second opinion?
So I called for a second opinion, I called for geriatric doctor. Yes, through that second opinion, by bringing in that second doctor, we managed to stop that movement of the original doctor to accept and say, it's over. She said, this lady has got a reason to live. She was allowed anything to drink and eat that she wanted. She just improved after that. Really now she's in a nursing home. And since she's been there, she's just one of the most popular old ladies in that home. You might say, there's an old lady, she's 94, she's lived a good life. Which is what they said to me. Why are you bothering? I said, it's my mom. Don't take her away.
Now, Helen's mother, she was in her 90s. I have to ask myself, would that first doctor, had he known that she was in her 80s or 70s or even 60s, would he have made a different diagnosis? And how would the story have ended if there was nobody there to fight for her?
At the moment they gave her the injection, they said they gave it so that she could go to sleep. But in fact, they just killed my mother.
Marguerite Vandervalk's mother was admitted to hospital for pneumonia, but she says that's not what killed her.
I drove to the place where the hospital is, and I got a private call from a private number. And there was a voicemail from a doctor from the ER. I called him back, and then he said, "You don't have to hurry, because you will not find her alive if you come to the hospital." And he said, yeah, we had to give her an injection, so she will be in a coma, but it will be a coma, she will not wake up. So I said, but why? Why didn't you intubate her? And he said, I called the GP, and the GP said she was lonely, she was depressed, therefore we decided that it would be better not to treat her anymore. The doctor called me in the middle of the night and said she had passed away. And I said, the cause of death, what's the cause of death? And she said pneumonia and heart failure. But I thought, I was laying in my bed, I thought, no, that was not. It was that little injection you gave her. The decision is not for a doctor who said, well, long and intensive care, yeah, not good in society, okay, put her in that room, she's going to die. Next patient.
Some politicians in the Netherlands are wondering if the country's laws are becoming more dangerous than the diseases.
See the slippery slope in our country.
Kies van der Stal says he has a warning for the rest of the world.
From my point of view, it's a very important task of government to protect the life of the citizens. And what we now see is undermining of the rights of life, undermining of vulnerable people or medically fragile or socially vulnerable, that it's no longer evident that their lives is worthy.
You had this law in 2002, the law that was passed. How do you explain it to people, the slippery slope, in very, very simple terms?
Each year there are more situations brought under this euthanasia law. In the last 10 years, now a growing number from two groups, that was people with dementia, and the other group is people with psychological or psychiatric suffering. That's not at the end of their life, but there were two categories that are expanding now.
In the past 10 years, the number of people seeking euthanasia in the Netherlands has more than tripled, from 2,000 to 6,000 annually. 200 of those are people with dementia and mental illness.
We do slide down with demented, brain diseases and psychiatric cases. Over 2016, these two groups together were 200 of the 6,000. That's small. That's always the argument the review committee says, "Don't worry, Mr. Chabot, it's only 200 cases and we do 6,000. What is the percentage? It's less than 2% or so." So that's the way they reassure the public. But I say, well, it may be only 1 or 2%, but look at the steep rise in 7 years. Look at the percentage done by the life-ending clinic without a treatment relationship. And then you see that people who are fighting their fear of life and fighting against death flock to the life-ending clinic. And then you see that there is, in those brain diseases, a slippery slope.
End-of-life clinics like this one in the Netherlands are increasingly popular options for patients whose doctors will not agree to end their lives. You're the experts in euthanasia.
Yes, absolutely. We are a second chance for a person that is not having the possibility to have his euthanasia wish honored by the own GP in particular. We're a standalone organization, fully independent, and it was notified that there were a group of people who had difficulties to have a response for their requests from their own doctor.
Can you give us a ratio of how many people call, request a euthanasia at the end-of-life clinic?
Well, roughly it's one-third, one-third, and one-third. One-third we can honor the request. So one-third will have euthanasia.
How much time will the doctor spend with the patient who's requested this?
Normally that's an interview of about 1 to 1.5 hours. And on average, 4 or 5 of these interviews are being done before they end up in the conclusion that they will provide euthanasia.
How does the end-of-life clinic deal with psychiatric patients?
That's a rather complex matter. And that means that it can take us 12, 15 visits and meetings before we come to a conclusion. Another reason that I'd like to give is a person with dementia. He was really very well prepared for the moment that he said, there is a moment that I will lose my capabilities of thinking, understanding what is happening, speaking. And before that moment is there, for then it will be irreversible, and I will not be able to express my opinion. Before that moment, I want to die, which is the situation with dementia.
So the fear what is to come.
That's in particular in dementia is that situation. Yeah.
Is it fair to say then autonomy, self-determination rules the day?
Absolutely. Absolutely. It's the ultimate help.
The ultimate help.
Yeah.
Oversight is a big concern in the Netherlands. In 2016, the media reported that a doctor was charged after euthanizing a patient who had to be physically restrained by the family. The patient had said they wanted to be euthanized in case of dementia, but physically fought back when the doctor was giving the lethal injection.
My simple answer is that is a crime. That is just a criminal act by a medical professional. Because she said, I don't want it, and he still did it. That's murder. Simple as that. Just 10 seconds before I put the injection in, I say, look in the eyes, and I say, is this what you really want? And if you say, I'm hesitating, I stop immediately. And maybe after 5 minutes you say, yeah, I mean, that's the kind of thing which is happening. And if the patient has written down whatever, if you orally say no, then no is the answer.
Dr. Jacquier says it's murder, but a legal review found the euthanasia was performed in good faith. Some people express their wish to be euthanized in advanced directives, also called living wills. The problem is people can change their mind, but the living wills are considered legally binding. 220 Dutch doctors recently published an advertisement in a national newspaper saying our moral reluctance to end the life of a defenseless human being is too big. The doctors believe it's wrong to kill a patient based on a statement they can no longer confirm. Rob Bruntink is a journalist covering palliative care in the Netherlands. He says what terminal patients are looking for is comfort and compassion, not a way to kill themselves.
They have this written will or advance directive about euthanasia, but when it comes to a certain point, their wishes to have this euthanasia doesn't exist anymore when they feel the care and the attention and love and warmth that people can give to a patient in a hospice.
He says euthanasia is increasingly becoming a catch-all solution for problems society would rather not tackle.
Because you have to talk about all those things like difficult stuff, hope, suffering, a lot of nasty symptoms. Euthanasia is kind of a clean subject. Well, you suffer, well, we can end it. Well, cool, let's do it. So I guess that's one of the reasons why we talk a lot about euthanasia and almost nothing about palliative care in general.
But despite the concerns, euthanasia is becoming more popular and more accepted in the Netherlands. And there's no better proof of that than the annual Week of Euthanasia, organized by the NVVE Voluntary End of Life Society. Euthanasia Week held a symposium specifically for people under 40 years old.
Why is it important to get the young people involved in this debate?
Because young people have, in several ways, to deal with end of life. Their grandfather, grandmother sometimes passes away, so they have questions about euthanasia or assisted dying. We don't promote people to take everything into their own hands. But whenever they want to, we provide them with information, what's the best way to do it.
One of those young people who came to the conference is Aurelia Brouwers. She came to the symposium because she wants to die.
So Aurelia, what is today all about? Why is it important for you to be here today?
I'm very interested in euthanasia, and I have severe psychiatric problems, and I want to have euthanasia because I have problems for about 13 years. And I have a death wish for about 6 years, and I've tried to get euthanasia for about 4 years, and I don't get it.
You don't get it.
And I just want to fight for it. And I even go so far to get into politics, to fight for a better law for all patients for all psychiatric patients, to get a better chance to get euthanasia if they are not treatable anymore.
We've just met, we've connected, you and me, we've connected.
Yeah.
And you seem happy, smiling.
But that's the problem with psychiatric patients.
Yeah.
Most of them seem happy.
Yes.
And so most people, most doctors, they think, oh, they look happy. So we don't give them euthanasia, but you don't know what happens when they got home.
Right.
Then maybe when I go home, I go to the bathroom, I get a knife, and I cut myself.
And what if tomorrow they said, we're going to give you as much support as you need, and we found a cure, we've found something. Would you change your mind?
I don't think there's any cure for me left.
So no hope?
No, I don't believe there is any.
I have to ask the question, who has failed her? Has the healthcare system failed her? I can't help but think of her and just see how beautiful she is. I want to give you a big hug.
You may.
So can I? Okay, good. Because,
If euthanasia for the terminally ill leads to euthanasia for the non-terminally ill, which leads to euthanasia for the psychologically ill, where does it end? How about euthanasia for people who are simply tired of being alive?
There are two proposals now, one by the government and one by a liberal opposition party, and both want to enact assisted suicide for people who are not ill, who are not suffering from any illness, but who have the feeling that they are weary of life, that their life is completed, that their life has become pointless. The one proposal is of a party who say this should be, only elderly people should qualify for this kind of assisted suicide. The other proposal says no, there shouldn't be any age limit. An 18-year-old girl or boy should also qualify for assisted suicide if he or she believes that their lives are pointless.
In the Netherlands, they call it the completed life.
The discussion about completed life is about relatively healthy older people who are just tired of life.
Dr. Els van Wijngaarden is a postdoctoral researcher in the Netherlands. She's a neutral investigator who has written a book called Ready to Give Up on Life.
It's a different discussion because it's not about medical grounds anymore.
Many of the people she interviewed for her book wanted a better life, but had given up hope of it ever happening.
A lot of people talked about For example, the pain of not mattering anymore, not being needed anymore, feeling redundant, being a burden to other people.
The study found that the participants' wish to die had to do with everyday realities such as fear, sadness, loneliness, and depression. There was a strong desire to feel valued and appreciated. We asked euthanasia advocates who would qualify for the completed life under this proposed law.
People who are wary of life might have some problems with hearing or seeing, but they don't qualify for the medical diagnosis involved in the euthanasia law. We noticed that these elderly people who were wary of life didn't get their wish to have euthanasia granted with the physicians, only when they had severe complaints together with growing old, like a lot of pain with joints, etc., and incontinence.
If that existential suffering is worse enough, and you say, I don't want to do that, and you can convince me, and I have no options to make it better, then you actually comply with the criteria.
But why is he coming to the doctor if it's not a medical problem?
Because the doctor is the only one who has the key to the cupboard where the right medication is.
It's not a completed life. It means it's uncompleted life. Their life is not completed. Yeah. And that's the problem. And I don't know how to make a new law for these people. I'm very afraid what it will mean for people, for elderly people. Because when we should have such kind of law, all people are thinking, well, when this is possible, what does it say about my life, the worth of my life? It would be terrible.
The next front line in this life or death battle is the United States of America. California, Colorado, the District of Columbia, Oregon, Vermont, Washington State, and now Hawaii all have assisted dying laws, along with Montana, which has a defense of consent provision. And as of 2018, similar laws are being developed, discussed, or debated in 25 other states. It's important to distinguish the difference between euthanasia and assisted suicide. They're similar, yet different. In the case of euthanasia, the doctor lethally injects the patient. In the case of assisted suicide, the doctor prescribes lethal medication that the patient would then take themselves.
We're heading into a tipping point in the assisted suicide issue in the U.S. They're selling assisted suicide as a form of freedom. And that's what seems to resonate with Americans. It's my choice. I can do what I want.
It's about the value of life. It's about caring, not killing. There are cases in the court system right now that could very well end up before the court. And then in one fell swoop, the Supreme Court could turn the entirety of U.S. law on assisted suicide upside down. We've seen it in other countries, we've seen it in Canada, and it's coming. We know that it's coming, and it could unleash a tsunami of death on our country.
That very few people are asking for euthanasia or assisted suicide because of actual pain. It's because of fear of future suffering. Now we know the assisted suicide lobby, they're telling us people are suffering and we're going to eliminate that suffering. But in fact, we can eliminate suffering without killing people. That's totally possible. The reality is this is about giving doctors the right and law to be involved with causing your death when you're at the lowest time of your life, when you actually need good supports, not lethal drugs.
In an Oregon study, participants were asked to rate their reason for requesting assisted suicide. Not one rated their current pain as greater than 2 out of 5. Still, many died by assisted suicide.
Of all places, to come to the medical profession and say, we'd like for you to specifically douse that flame of life. That is an anathema to the medical profession. If you were just to replace the image of the needle or the pill with the gun, I think that would make a much more vivid picture of something that I think we can agree would be transculturally wrong. And that if you wish to make that a right rather than a freedom for patients, we will stand in a position of protection by at least girding ourselves with an ethical proscription that forbids us to participate in helping our patients. That's not what we do. We prevent.
Besides the American Psychiatric Association, the American Medical Association, the American College of Physicians, and the World Medical Association all reject doctor-assisted suicide.
This is an issue that's about making the medical professional more comfortable with killing people. And I've heard testimony in legislatures where our politicians, the people sponsoring and supporting these bills, will say words to the effect of, well, doctors will have to be trained, to do this. Doctors will have to become comfortable with, doing assisted suicide.
Did you ever suggest to any of your patients?
Well, that's my concern, is that physicians will come to approach this as a suggested treatment option. The potential for someone to persuade or to encourage or to guide someone in the particular choice certainly is there, and it could be done.
The most common reason people with paralysis die are from wounds, meaning a pressure sore. I've been paralyzed for 40 plus years now, and I have only had one wound, and that was in 2010. And it was a massive wound that was life-threatening. A physician in the middle of the night came to my room. He said, "Are you aware of how sick you are?" And I said, "Yes." And the physician went down a laundry list of things that could happen. That I would most likely go bankrupt because this wound would take up to 2 years to heal. I may never sit up again. That the odds of healthcare covering all the costs that I would be incurred were remote. That I may never work again, I may never sit again. But at the end of this cavalcade, at the middle of the night, he said, "The decision to take life-saving antibiotics are yours and yours alone. I can make you comfortable if you decide to forego those life-saving antibiotics." He was very politely asking me if I wanted to die, and he would have made it happen. If I were a 50-year-old dentist that came to the same hospital and needed 5 operations on my hip and limb lengthening because my femur is shattered, would not be offered that same opportunity. And I remember that next day, I called my siblings. I said help for the first time. And I had them write PhD on my chart. That was all because I was afraid.
Welcome to Death with Dignity.
I've never been welcomed to Death with Dignity before. When I visited Death with Dignity, the organization was recognizing 20 years of the laws passing in Oregon.
We're the organization that really works to get the law passed in other states. We work with lobbyists and legislators and governors to get laws passed, kind of the political process, the behind-the-scenes process.
And what is Death with Dignity?
Death with Dignity is a policy that's defined in law. And what it does is it takes a medical standard of care for what a physician or pharmacist should do if a patient requests a hastened death.
When I looked through your report from 2016, the Oregon Death with Dignity Act, Data Summary 2016, one of the underlying conditions was diabetes. And to me, that kind of jumped out of the page of me and said, some with diabetes access this law? And we have thousands and thousands of people who live with that condition and would die without their insulin.
So that's very rarely used. It's not one of the top, right?
But is it used?
It has been used, definitely. It has been used for diabetes. But the fact is that for those cases, you and I have not evaluated that patient, but we don't know what else was going on with the patient. We don't know if there were coexisting disorders.
So it's on the doctor then?
It's on the doctor, right.
That's a lot of responsibility to put on the doctor.
And we want that. We want, if a physician is going to prescribe, we want them to have a great deal of responsibility.
If conditions like diabetes are qualifying under the law, where are the stringent safeguards protecting the system from abuse?
The way the law is written is that 2 physicians have to evaluate the patient, and both physicians have to come to independent conclusions that the patient has the capacity to make healthcare decisions. If there's anything in the patient's record or anything that is part of the examination that either of the physicians feel like there is a question about whether or not this patient can make healthcare decisions, then the process stops, and the patient has to be referred for counseling, for an evaluation, and for treatment before the law can go forward.
That's what the law says, but this Oregon doctor says that's not what's really happening.
I had another patient who was diagnosed with a malignant melanoma, metastatic cancer, form of cancer that's got a very poor prognosis. And he was quite depressed because he was an avid outdoorsman, loved to hike, loved to be outdoors, and he was diagnosed and he was seeing his oncologist, and he was quite depressed about it, and she even documented that in his note, and he went to his cancer doctor, and she called me and said, this patient really wants assisted suicide, and I need to be the second opinion. And I said, well, no, let's wait a minute. Number one, what's going on? Let's talk about this. Well, what happened was that she must have found someone else, because 2 weeks later he was dead from an overdose of a medication. And so my colleague saw a patient with depression, but instead of addressing his depression, she gave him the means to kill himself.
You were the second opinion, were you not?
I was.
And so they went for a third until they got the answer they wanted?
That happens all the time here in Oregon.
The patient that I specifically recall is a patient by the name of Jeanette Hall, and she was referred to me by her surgeon. She had a low rectal cancer. So when I saw her, I told her what she had, and she said, I told her we could treat it with radiation and chemotherapy. And I said, well, this is potentially treatable. And she says, I don't understand. I don't want to go through all that. I had an aunt who lost her hair, and I don't want to lose my hair. And she went back and saw the surgeon. The surgeon told her that if she wasn't treated, that she would be dead within 6 months or a year. Now, the Oregon law says that if your life expectancy is 6 months, you qualify for the law. So I could have written her a prescription for the lethal medication at that time. But she came back, and I talked with her again, and she said, why aren't you giving me the pills? I want the pills. I learned more about her and learned that she had a son. He was going to the police academy. I said, well, wouldn't you like to see him graduate? And that really made her think that, hey, I do have something to live for. She really struggled in her mind as to whether she was going to be treated or not treated. She finally accepted the treatment. It took a few weeks to give. It was not easy. She actually did lose her hair, but the hair grew back. And she was able to attend her son's graduation from the police academy. 5 years later, my wife and I were at a restaurant, and she was there with a friend, and she came over and she said, Dr. Stevens, you saved my life. If I had gone to a doctor that believed in assisted suicide, I would not be here. I'd be dead.
It's the King's English. The euphemisms driving this debate are the so-called choice in dying, options at the end of life, so-called death with dignity. So my wife that died 3.5 years ago of a metastatic leiomyosarcoma of the uterus, we were blessed with 5.5 years of life once the diagnosis of metastatic cancer had been made, which was about 4 times what had been predicted. And I treasure every moment that we had. Well, if taking a massive overdose of medication to kill yourself is dignified, then what does it say for the majority of people who die naturally, like my wife did 3.5 years ago, at home, peacefully, with family surrounding her? But she didn't take an overdose, so that's not dignified?
So what assisted suicide laws do is they manipulate people by redefining terms.
Alexandra Snyder is a lawyer fighting against the expansion of assisted dying laws.
You can phrase it aid in dying, you can call it assisted dying, you can call it whatever you want. The fact is, it encourages people who are vulnerable to kill themselves.
Language is vitally important in this debate. Whether we're talking about assisted suicide or death with dignity, think about the difference between those two phrases. One of them sounds bad, and when you ask a polling question saying assisted suicide, you get one result. When you ask that question with the phrase death with dignity, of course everyone wants dignity. It's a positive phrase.
My job as a doctor is to alleviate their suffering. It's not to be a vending machine when they make a good, rational argument that they'd be better off dead. It's like being a lawyer for the defense and the lawyer for the prosecution in the same courtroom. Am I arguing for the health and well-being to extend life as long as is reasonable? Or am I advocating for their early demise because after all, they're going to die anyhow? And then, by the way, if you don't think that's a conflict of interest, I'm also the judge to decide which argument's the best. And if you're not bothered by that, I'm also the executioner. There are about 200 doctors in the state of Oregon who believe they can keep all that conflict of interest straight. It's a delusion. If society is going to do this, if they believe that situational killing is the right answer for some illnesses, diseases, some points in life, then it should be someone outside of the house of medicine to avoid that inherent conflict of interest. Because after all, up until recently, there is no crystal ball reading course in medical school. And I say up until recently because for the first time in my university, in my department, some of my colleagues were teaching young doctors in training how they go about ending their patients' lives.
How important is language in this debate?
Language is a critical factor here. And as I think a famous person once said, all social engineering is preceded by verbal engineering. So if you can change the words, you can change how people think about it. But it's important to understand what assisted suicide is. Assisted suicide is the direct and intentional ordering of the death by a lethal overdose by a provider, physician. And it's self-ingestion of this lethal medicine, which is a...
Well, a typical suicide, if you think about it, is a violent, irrational act. And what death with dignity does is it adds a dignity to the process, it adds the physicians to the process, but this is very different from in terms of this is a rational act by a person who's dying to control the timing and manner of their death.
So these laws are a recipe for elder abuse. Let's say that person had a moment where they thought, I just want to have it here just in case. It would make me feel more comfortable to have this aid in dying drug in my home in case I want to take it. And then they change their mind and they say, no, I don't want to take it. Or what if their diagnosis is not accurate and they say, wow, I just got a new lease on life. That drug is still in their home. Somebody who, again, has perhaps financial motives or other nefarious motives can conceivably force that person to ingest those drugs, resulting in their death, and there would be no investigation. The presumption would be that person chose to kill themselves, was successful in doing so, case closed.
When you're talking about a family who's looking at a frail elderly person and looking at the cost and the expense and saying, you know, why don't you just do assisted suicide, save us all the time and
Does
trouble?
that happen?
Yes, it happens. And how much of a choice is that for you who now feels obligated to end their life, not because of your autonomy, but because of the pressures now that you face in your family? So how much of a choice is that?
That's just a microcosm of the coercion that can take place here. You know, you have coercion from family members, coercion from a facility that perhaps wants to free up a bed, coercion from a health insurance company that doesn't want to keep paying for your cancer medication or whatever it may be.
So if you're terminally ill, if you're disabled, if you're even temporarily incapacitated, you're no longer considered part of the human community, and your life is now expendable. And it's a purely material, purely fiscal consideration. And that is not how we ought to be viewing human beings.
I've traveled 50,000 kilometers and talked to dozens of people on both sides of the issue. But the story doesn't end there. Remember Aurelia, the 29-year-old woman I met in Holland who wanted to be euthanized due to psychological illness? We maintained our correspondence even after I returned to Canada.
In December this year, last year, I got news that my euthanasia request was approved. So
it was approved.
Yes. Today I got, I can tell you, I got from my pharmacist. I need to anti-vomit medication, and I got them today. I don't think you can see them very well, I think.
And what is it, did you say?
It's a medication so I don't vomit during the euthanasia.
Yeah.
And when I got them, I started crying.
Yeah.
So because no, that is also part of my, because I'm also mourning.
Yeah.
Because I don't choose to die, I choose to end suffering, and I choose because I know what, if I don't go on with euthanasia, then I know what the other option will be.
I don't pretend to know what Aurelia is going through, but for me, I pleaded with her to change her mind, to continue to seek help, to use the same coping mechanism she's used to continue living, that there's always hope, that the world is a better place with her in it. This would be the last time I spoke with Aurelia. We've seen the law in the Netherlands expand bit by bit, from the terminally ill to the chronically ill to the mentally ill to those who are simply tired of life.
I do respect the choice people make under difficult circumstances, but we have failed to find the boundaries, and the boundaries are blurred to an extent that we are shifting all the time.
To those people who say it can never happen here, I would say this. I never thought it could happen here in Oregon. Who in their right mind would give their doctors the ability to kill their patients? Who would do that? Don't they see that there's just inherent harm in this strategy? That it could be taken to lengths that they can't imagine?
If I could do one thing, it would be just to undermine the myth of autonomy, that we have this right to die. No, we don't have a right to die. We have a right to live.
Today, I'm taking my dad for a checkup with his oncologist.
Hey, Daddy-o, how are you?
Pretty good, thanks.
Good. Ready for your checkup?
One day at a time, that's what I say, yeah.
It's been 3.5 years now since his diagnosis, and Dad is pretty much cancer-free. If fear of suffering or becoming a burden are the reasons people lose hope, it's up to each of us to become the reason for somebody's tomorrow.